Hello, my name is Sandeep Devabhakthuni. I am an assistant professor at the University of Maryland School of Pharmacy. I specialize in the area of cardiology. The title of my presentation is One Size Does Not Fit Most, Identifying the Blood Pressure Goals and Treatment Plans for Those with Cardiac Conditions. Hypertension remains as one of the leading causes of cardiovascular diseases. Because of this, many national organizations are issuing published guidelines in order to guide clinicians in the treatment of hypertension. However, because there are so many different national organizations, there have been conflicting recommendations that have been published because there's some controversy depend on the definition of blood pressure goals. To illustrate this, I wanted to start off with a patient case. JM is a 62-year-old African-American man who presents for a follow-up visit 2 months after being discharged from the hospital for a non-ST segment elevation acute coronary syndrome. His past medical history is significant for hypertension and coronary artery disease. And he's had 2 myocardial infarctions, once in 2010 and the other one now in 2016. His current medications include aspirin 81 milligrams daily, atorvastatin 40 milligrams daily, lisinopril 20 milligrams daily, hydrochlorothiazide 25 milligrams daily, and metoprolol 50 milligrams twice daily. And today, during his visit, his blood pressure reads 138 over 688 millimeters of mercury. So the question becomes, what is an appropriate blood pressure target for JM? And it really depends on the guidelines that you refer to. Based on the new guidelines from the Joint National Committee that was published in 2013, because of his age, which is greater than 60 years old, his blood pressure goal would be less than 150 over 90. However, he does have some risk factors that would put him at a higher risk for a myocardial infarction, which would include previous history of acute coronary syndromes and having coronary artery disease. And so other guidelines from American Heart Association and the American College of Cardiology have recommended to have a lower blood pressure goal for patients with higher risk factors. And so they would recommend to decrease it to less than 140 over 90 or even further to less than 130 over 80, depending on the risk factors. So it is really important to consider patient characteristics when defining the blood pressure goal. So hopefully by the end of this presentation, you'll be able to determine a blood pressure goal for a patient with heart failure and or coronary disease. When given a patient case, you'll be able to develop an antihypertensive regimen for a patient with heart failure and or coronary disease. First, I'd like to start off with some hypertension statistics. As you know, the hypertension is fairly common in the United States. Approximately about a third of the population have hypertension, which puts them at a higher risk for myocardial infarction or stroke. For patients who have stroke, about 77% of these patients have a prior history of hypertension, which highlights the need to manage their blood pressure appropriately. And finally, for heart failure, one of the most common reasons for developing the heart failure is due to hypertension. In fact, 75% of patients have a prior history of hypertension. Because of the high blood pressure, this causes a lot of stress to the left ventricle, which causes it to remodel, and then that can lead to the development of heart failure. So again, this is really important to make sure that your blood pressure is controlled appropriately. As I mentioned before, there have been several different national organizations that have been involved in creating hypertension guidelines, including the Kidney Foundation, the American Society of Hypertension, and the International Society. The Joint National Committee, the American Heart Association, the American College of Cardiology, and the American Society of Hypertension, as well as the American Diabetes Association. I just wanted to provide a summary of the goals that were published from these different organizations and highlight a few differences that might have been shown there. If you look at the American Heart Association one that was published for patients with cardiovascular disease in 2015, for patients who have high risk factors for myocardial infarction, which include coronary artery disease, post-MI, stroke, and a few others, the recommendation is actually to push it much lower than what some of the other guidelines are, which is less than 130/80. When you look at the differences in the age, you'll notice that for the 8th Joint National Committee guidelines, which was published at the end of 2013 and beginning of 2014, they have a different age cutoff compared to the other guidelines. And their age cutoff is age greater than 60. And for those patients, the goal should be a little bit more lenient with less than 150/90. However, there is not really much data to support this, and it might be too low of a cutoff. The other thing that I wanted to point out is across all the guidelines for the diabetes, it is actually pretty consistent with a goal of less than 140/90. And this is a change from the previous Joint National Committee guidelines, which used to have a goal of less than 130/80. Now I would like to focus on the 8th Joint National Committee guidelines, which is the most common used one in practice today. The guidelines first recommend to consider lifestyle modification, which include diet, exercise, weight, and alcohol abuse. Then they divide it based off whether or not the patients have diabetes or chronic kidney disease. If the patient does not have those risk factors, they then divide it based on their age. If the age is greater than or equal to 60 years of age, then the blood pressure goal should be less than 150/90. But if the age is less than 60 years of age old, then the goal would be less than 140/90. Regardless of what the difference in the age is, they should still receive different treatment. However, treatment is based on whether or not the patient is Black or non-Black. For non-Black patients, the 4 main categories of first-line choices are thiazide diuretics, the use of ACE inhibitors, and angiotensin receptor blockers, as well as calcium channel blockers, whether you do them alone or in combination. If the patient is Black, then the thiazide or calcium channel blocker are considered first-line agents for treatment. And the reason for this is the thought is that Black patients have lower levels of renin, and so they may not respond as well to ACE inhibitors or ARB therapy. Now let's look at the patients who have diabetes or chronic kidney disease. If there's a presence of diabetes but no CKD, then the goal is less than 140/90. And these patients would still receive the first-line treatment depending on whether or not they're Black or non-Black. And then finally, for the patients who have chronic kidney disease, plus or minus diabetes, the goal is less than 140 or less than 190. However, the first-line agents should be ACE inhibitor or angiotensin receptor blockers. And the reason for this is there is a compelling indication for a chronic kidney disease patient to receive these therapies in order to slow the progression of renal damage. So, there are many experts in the field, as well as other national organizations, who do not have concerns with the Joint National Committee guidelines. And one of the concerns is that there is no recommendations for patients with coronary disease or heart failure. And also, the choice of medication for the special populations are not addressed, and these include patients with heart failure or pregnancy. And then finally, the definition of older patient at the age of less than 60 is inconsistent with the other guidelines, and there is not really much data to support a lower age cutoff. So now, I would like to focus on the disease management for coronary artery disease. And one of the goals for hypertension management in this population is to reduce excess morbidity and unnecessary deaths. There is a theory that a lower blood pressure goal, as much as you can, is better for the target. And this is actually supported by a subgroup analysis of the Camelot, which was a study that was conducted evaluating the use of enalapril versus amlodipine. And this one showed that having a lower blood pressure target of 120/80 was associated with a decrease in progression of coronary artery disease. However, though, this was actually just using surrogate markers. The use of a lower blood pressure target is still intensely debated because it is not consistently supported, and there's very few high quality randomized clinical trials. The reason why this is still debated is because having a low blood pressure target can be harmful, and this is really measured by looking at the diastolic blood pressure. If you recall, the diastolic blood pressure is a measure of your perfusion. And if you have it too low, this could decrease the oxygen supply to your vital organs. So you may have heard of the J-curve phenomena, which refers to at high blood pressures, you have an associated risk of increased risk of myocardial infarction and stroke. However, there is also a concern with lower blood pressure. If you have a too low of a blood pressure, this could be associated with an increased risk of mortality. And so there have been studies that looked at the optimal systolic blood pressure as well as diastolic blood pressure. The top bar looks at the systolic blood pressure. There was a trial called the On-Target trial that looked at patients who were at high risk and had coronary artery disease. And they did not really show much of a J-curve with the systolic blood pressure. So this one basically showed that you wanted to get as close to 130 or lower for your systolic blood pressure to see the optimal outcomes. At lower blood pressure, it did not seem to have an association with increased mortality. Now look at for diastolic blood pressure. There was another trial called the TNT trial that was another randomized control trial in CAD patients. And this one looked at the treatment for diastolic blood pressure. And as you can see, greater than 100 was definitely associated with increased mortality due to reinfarction or stroke. But you can also see that at lower ends, such as 60 and 61/70 for your diastolic blood pressure, was also associated with increased mortality. So the optimal range for diastolic blood pressure was between 70 and 80. So now that we've talked about the difference in the blood pressure goals, there were a couple of trials that looked at using a lower target goal. The first one that I wanted to discuss is called the ACCORD trial. And this was actually conducted in about 4,700 type 2 diabetic patients. And what they did was randomize these patients to either receive the intensive blood pressure control, which would have been a blood pressure less than 120/80, versus the standard blood pressure goal, which is less than 140/90. They used pretty much standard blood pressure therapies for decreasing your blood pressure, including thiazide diuretics. The thiazide diuretic that they chose, though, was hydrochlorothiazide. They also used amlodipine as well as ACE inhibitors. Basically, the main finding that they did with the primary outcome, which was looking at the cardiovascular death, there was no significant difference, except in the finding of stroke. Having an intensive blood pressure control did find that there was a decrease in the risk of stroke in patients with diabetes. When they also did a subgroup analysis looking at diastolic blood pressure of 60 to 65, and those that achieved that goal, there was a trend towards a decrease in cardiovascular events. However, this was not statistically significant. So based on this trial, there didn't seem to be a great push for doing intensive blood pressure control. However, there was a possible decrease in a stroke if we were to drive it down there, and there did not seem to be an association with harm. Now, there is actually a newer trial that was actually published recently in 2015 called the SPRINT trial. And this one did also do the same thing. However, they actually looked at non-diabetic patients who are at high risk for cardiovascular disease. And this was about 9,400 patients, almost twice the size of the ACCORD trial. And they also randomized patients into an intensive blood pressure goal group of less than 120/80 versus the patients in the standard blood pressure group, which would be less than 140/80. And what they found was a dramatic improvement in patients who received intensive treatment. And this was actually about 25% reduction in mortality. The one thing I wanted to point out as far as the therapies that were given, one of the ones they chose to use was chlorothalidone over using hydrochlorothiazide as their thiazide diuretic. And this may have made a difference because chlorothalidone has been shown to have an improvement in mortality over hydrochlorothiazide. However, while these were great findings, there were some cautions that should be advised. The authors did note that there was an increase in the risk of hypotension as well as an increase in renal failure by using intensive treatment. However, this was a pretty low percentage compared to the reduction that was seen. So this could be considered as a benefit versus risk analysis. The other problem that you need to be considered is that the patients in the intensive treatment group were more likely to receive a higher number of drugs, which would be 3 or more drugs compared to the standard group. So this is also something else to consider for patients who have a problem with medication compliance. But the take-home point for this trial was that it might actually be appropriate to consider intensive blood pressure goal for patients who have a high risk for cardiovascular disease. And the other thing I wanted to point out for this trial was there were many patients that were over the age of greater than 60. The mean average age for this trial was around 65. And so I wanted to point this out because the current JNC guidelines recommend a much higher blood pressure goal for patients with an age of greater than 60, which may not have been appropriate based on the findings of this trial. Based on the results of the trials, there are some recommendations that can be made for the blood pressure goals in patients with coronary artery disease. For patients who require secondary prevention of cardiovascular events, the recommended blood pressure goal should be less than 140/90. For high-risk patients with coronary artery disease, so that would include patients with previous MI or stroke or transient ischemic attack, as well as risk equivalents such as carotid artery disease, peripheral artery disease, and abdominal aortic aneurysms. There is a reasonable goal of less than 130/80. What about for patients with acute coronary syndromes? Unfortunately, the blood pressure goal has not been well studied in literature. We do know, however, that most of the first-line agents used for blood pressure treatment there's great outcomes for patients with acute coronary syndrome. And so we usually go based off the compelling indication for acute coronary syndrome. So the target blood pressure goal is less than 140/90 immediately post-acute coronary syndrome. And the American Heart Association, in conjunction with the American College of Cardiology, did have recommendations of considering a goal of less than 130/80 at discharge, which would be considered reasonable. However, there is no data to support this. So just to summarize what the hypertension treatment choices are for patients with coronary artery disease. So starting with coronary artery disease or chronic stable angina, The first line therapies is the combination of beta blockers as well as the ACE inhibitor or angiotensin receptor blocker. These should be considered the first ones to choose in managing the blood pressure. Then, if there still is a need to add another agent to control the blood pressure, you can either choose a thiazide for blood pressure control or a dihydropyridine calcium channel blocker for ischemic or blood pressure control. The calcium channel blockers can be used to manage their patient's anginal symptoms. For patients with acute coronary syndrome, the first-line therapy should include beta blockers as well as ACE inhibitors or ARBs, because these have been shown to decrease mortality. ACE inhibitor or ARB specifically reduce mortality in patients who also have presence of left ventricular dysfunction, which is associated with a lower ejection fraction of less than 40%. And then if there still is a need to add another agent, then you could either choose to do a thiazide or a dihydropyridine calcium channel blocker if the patient has a normal left ventricular ejection function. However, if there is left ventricular dysfunction present, then aldosterone antagonist should be your third agent, because there is a mortality benefit demonstrated in a trial called the Ephesus trial. So now let's move on to defining the blood pressure goal for heart failure patients. There is no definitive data for optimal blood pressure goal currently, and there have been no randomized controlled trials. So the guidelines have recommended do a conservative recommendation of less than 140/90. However, these patients have a low ejection fraction of less than 40%. And so that increases the demand on the heart by having a high blood pressure. And so it is really important to consider a lower goal of less than 130/80, especially in select heart failure patients who have a hard time with maintaining the reserve. And in fact, there are some clinicians who actually will drive it even further lower to less than 120/80 to allow for the heart to compensate well. There is a little bit of evidence in the heart failure population from large randomized controlled trials. And most of the trials that were conducted actually lowered their systolic blood pressure to about 110 to 130. And they actually showed a reduction in mortality. And then there was the Copernicus trial that looked at carvedilol in severe chronic heart failure patients. And basically the entry criteria actually included patients as low as 85 millimeters of mercury with a mean pre-treatment of blood pressure 123/76. And they still found a reduction of 27% in combined risk of death or hospitalization for a cardiovascular reason. So based on this data, there is support to go for a lower blood pressure goal compared to using the standard of 140/90. What about for patients with preserved ejection fraction? So there was a trial called the EXCEED trial that did a randomized controlled trial in patients with heart failure that had a preserved ejection fraction. And they randomized patients who had an intensive regimen versus the standard regimen. The intensive regimen had a blood pressure target of less than 130/80 compared to the standard regimen. And so they used amlodipine and valsartan as their blood pressure agents. And what they found was there was actually a greater improvement in diastolic relaxation with lower systolic blood pressure, which indicates that hypertension should be managed appropriately in heart failure patients, and this can actually improve symptoms for this population. So one of the main managements for a patient with heart failure with preserved ejection fraction is to manage their blood pressure aggressively. And so based on this trial, it is reasonable to consider a lower blood pressure goal of less than 130/80. So let's review the choices of agents for heart failure management. And for these, this is really driven by evidence-based guidelines of treatment because there's many medications that actually decrease mortality. And so the first line agents include the addition of a beta blocker, specifically the metoprolol succinate, bisoprolol, and carvedilol, since these have been the ones to reduce mortality. Then this should be in combination with ACE inhibitor or ARB, as well as aldosterone antagonist. If blood pressure is still required treatment, then you would consider using a thiazide or thiazide-like diuretic if the patient has mild heart failure and no renal failure. Sometimes the thiazide, especially hydrochlorothiazide, would not work in patients with severe renal impairment. If the patient requires volume control or has moderate to severe renal impairment, then loop diuretics is preferred. And then finally, if the patient is African American, then there is a recommendation to consider using hydroxy and nitrate combination because this can decrease mortality. Now, I would like to return back to the case and apply what we just learned about the blood pressure goals for depending on their patient characteristics. 3 years later, J.M. presents to the hospital due to progressive dyspnea on exertion, bilateral ankle edema, and elevated jugular venous pressure, and bibasilar pulmonary crackles. The chest X-ray was positive for moderate to severe pulmonary congestion. The echo was significant for increased LV dilation and ejection fraction of 25%. His current medications include aspirin, atorvastatin, lisinopril, hydrochlorothiazide, and metoprolol succinate. And his current blood pressure is 160/85, and his heart rate is 86 beats per minute. If you recall, his past medical history is positive for hypertension, coronary artery disease, status post 2 myocardial infarction, both in 2010 and 2016. So, what would be an appropriate blood pressure target for him in the setting of this new onset heart failure? So, based on the guidelines, you could consider using a blood pressure goal of less than 140/90. However, because it's of his significant risk factors, it might be a good idea to consider even lower goal of less than 130/80. And honestly, when you start putting on all the medications that are used for evidence-based therapies in heart failure to decrease mortality, most patients usually have a blood pressure that's lower than 120/80. So, if you remember his current medication regimen, were there any changes that you would make in order to optimize his hypertension management? So, the lisinopril 40 mg daily is pretty much his maximum dose. However, hydrochlorothiazide might not be the best choice for him. If you recall, there are 3 agents that should be considered as first-line therapy. The patient is on a beta blocker and on an ACE inhibitor. So one thing we could add is an aldosterone antagonist, and so that such as spironolactone. You could also consider optimizing the metoprolol, but remember that you have to titrate it slowly in order to avoid side effects. Once you have optimized the beta blocker and have the redo and have the aldosterone receptor antagonist on board, you could also consider adding hydralazine and isosorbide dinitrate combination as another additional combination to decrease their blood pressure. And then if you're still having issues, you could then consider doing a thiazide diuretic. But the other thing that the patient probably might need right now is probably a loop diuretic for volume control. But it really depends on how much volume the patient needs, or control the patient needs. So in conclusion, I really want to emphasize that the blood pressure goal should be patient-specific based on what the risk factors for cardiovascular disease. The 8 Joint National Committee guidelines are really meant to be used for the general population and patients with diabetes and or chronic kidney disease. They are not really helpful for patients with other disease states. So please refer to the disease-specific guidelines for the management of cardiovascular condition and heart failure. This last slide is just a summary slide of all the blood pressure goals that we discussed, as well as the first line and sequential therapies to consider. Thank you.